Welcome everyone to the Portable MRI Journal webinar. This is, I'm Omar Islam, one of your co-hosts today, and I'll be introducing my co-hosts and panelists in a second. This is brought to you by Portable MRI Journal, as well as Queen's University Department of Diagnostic Radiology. We're very excited today to have two wonderful speakers from Harvard speaking about portable MRI. But before we go to them, let me introduce my co-host, Dr. Aditya Brata. Dr. Brata is a good friend and colleague from the University of Toronto, where he's a staff neuroradiologist at St. Michael's Hospital, Unity Health. He's an associate professor of medical imaging at U of T. And in Canada, he's one of the foremost leaders in portable MRI use and experience through the portable MRI machine, which is in the ICU at St. Michael's Hospital. I also have with us who's on our panelists, and he's kindly agreed to join us and help us answer your questions and be part of the discussion on portable MRI is Dr. Eddie Knopp from Hyperfine, and Pam Moore, who's our assistant coordinator in the Department of Radiology. Before we start, I think Pam just wants to give a couple of housekeeping messages, and then I will introduce our first speaker.
Yeah, I just want to say welcome. Thank you for joining us today. Just a reminder that you guys can see us as the panelists, but we can't see you. So the best way to communicate with us or to ask any questions or make any comments is to use the Q&A box. You can submit your questions there, and then our moderators can see that. The talk is being recorded, and it will be available to everybody within about a week of the session. Also, when you registered, if you commented or you let me know that you will need a certificate of attendance for CME or any other thing like that, those will be going out in the next few days based on attendance records. We will do the question and answer kind of towards the end, but you can put your questions in the boxes as the talks go on so you don't forget them, or if something else comes up, you can always add new questions. So I hope you enjoy our session today, and thank you for joining us.
Thank you, Pam. So I want to introduce our first speaker. I'm very honored and excited to have Dr. Matt Rosen join us as the first speaker. Dr. Rosen is a physicist, tool builder, and inventor whose research bridges the spectrum from fundamental physics to applied biomedical imaging work. He established the low-field MRI and hyperpolarized media lab in the Martino Center for Biomedical Imaging to focus on continued development of new hyperpolarization methods and MRI-based tools. He directs or co-directs the Center for Machine Learning at the Martino Center. He is Associate Professor of Radiology at Harvard Medical School and the Kiyomi and Ed Baird MGH Research Scholar. Also, last but not least, he founded Hyperfine in 2014 with Jonathan Rothberg and Ron Walshworth. So I'm very excited to have Dr. Matt Rosen with us. Matt, the floor is yours.
Great. And can you guys hear me?
Yes.
Great. Fantastic. Wow. Thank you so much. I mean, this is so exciting, you know, not only to, let me get my timer going so I don't go over time here. Sorry, there we go. You know, the fact that there's a journal around portable MRI is pretty remarkable. So there's just a real convergence of things going on. These are my disclosures. As we mentioned, I think most relevant to this is that I did found Hyperfine. Okay, so I want to talk about work we do in my group at the Martino Center in the Millitesla regime, typically around 6.5 millitesla. And just to clarify some things at the outset, that's about a factor of 10 below the Hyperfine scanner, which is at 64 millitesla. So this will come up a number of times. So I've been doing low-field MRI, Millitesla MRI for about 20 years. Back when I was in Ron Walshworth's group, our student Leo Tsai and I built a 6.5 millitesla scanner. That's a much younger me right there, with the intention of doing hyperpolarized gas imaging as a function of subject orientation. So with the patient standing up and the patient laying down, because we were interested in studying how the heart-lung system is affected by gravity. In 2009, I took the system apart. This was my then student, Stephen Devin, supervising, and set up my lab over at the MGH Martino Center. Around that time, Popular Science gave us the moniker the do-it-yourself MRI. And in thinking about low-field MRI over the last 20 years, I started to understand really that, like, we were doing kind of incidental low field MRI. You know, I had to build my own scanner so we could stand up and lay down. The signal comes from hyperpolarized, exogenously polarized materials. And so you didn't really need a large holding field to do MRI. So it was just easier to operate in the Millitesla regime. But around 2010, I got a large grant from the Department of Defense, really focusing on this idea that, you know, if you want to bring magnetic resonance tools into the battlefield or in forward hospitals, you know, those instruments could be potentially deadly in the presence of undisclosed shrapnel. And so what we've done in my group really is sort of like intentional magnetic resonance at low field. We've established, as I will talk about, kind of a series of techniques and sequences and hardware that are kind of an existence proof that neuroimaging is possible at 6.5 millitesla. And what that enables is that it enables operation anywhere. This is the hyperfine scanner. This is Taylor and I. You'll notice, of course, that this scanner is on wheels, right? Again, a high field scanner at 3 Tesla could not be on wheels for safety reasons. Of course, in the last few years, people are kind of getting the message. Even our society, the ISMRM, is sort of recognizing that, oh, low field MRI, it's a thing, right? And we had our first virtual workshop last year. And the kind of takeaway points from that are that, you know, some applications honestly benefit from operation at low field. We're not talking about like science fair experiments, right? There's real reason to do this. And we can exploit some strategies that leverage compute. Okay. So we get into a lot of things in my lab. If you met me in the 90s, you know, as was mentioned, you'd think of me as a hyperpolarized gas guy. But for the last 20 years, we've really been focused on Millitesla MRI. These things in yellow are enabling techniques for low field operation. And then these applications in green are things that benefit from operation at low field. Now, this is a long list and I don't have infinite time, but I want to give you a flavor for some of these things. So, you know, at the outset, you can't just turn the magnetic field down and expect to make good images because, of course, as we all know, we use inductive detection to measure the rather small thermal Boltzmann polarization, right? Nuclear magnetic moments are very small, what Richard Ernst referred to as the power of evil in magnetic resonance. And so if you want to make images like these, you turn up the magnetic field, right? And the problem is actually even worse. Remember, this is inductive detection. So the signal goes like dB dt, so like B squared. In the Johnson noise dominated regime, not the body noise dominated regime, at low frequency, you're in the Johnson noise regime. The noise goes like, of course, Johnson noise, which goes like square root of B. And so you end up in a situation where your signal to noise goes like B to the 3/2. So what kind of images would you expect to make at 6.5 millitesla, roughly 500 times lower magnetic field than a 3T scanner, where the B to the 3/2 factor is 10,000? Well, you'd probably expect and not be surprised that these are the kind of images we were making back in 2005. These are a single slice of a human head, if you can believe it, acquired at 6.5 millitesla in about an hour. And so what I want to talk about really is how we chose to solve this hard problem, really enabling MRI at low magnetic field through a combination of physics and compute. And you could really think of the physics as, you know, how can you interrogate the system so that you maximize your acquisition SNR, the SNR in your preamp, let's say. And then once you acquire that data, what can you do to reduce the noise, or what the kids call fixing it in post? Now, all of you know that you're going to have to do signal averaging. Again, the story I'm telling is about 6.5 millitesla. Some of these things translate to the hyperfine scanner, some don't. So please take them on their own. And so signal averaging, of course, is a painful reality at 6.5 millitesla. You know, you win by the square root of the number of averages, which isn't great, but at least you're winning. So in my lab, if we want to typically acquire like a 64 by 75 by 15 matrix, we need about 30 averages. That's about 3,400 total acquisitions. And let's just look at the sequences you all know about and how well do they work at ultra low field. Well, a gradient echo is great. You do a 90-degree pulse, right? And then you wait for thermal recovery and you do another 90-degree pulse. T1s are shorter at low field, so that helps a little bit, but it's still around 750 milliseconds per shot. And so that acquisition time takes 40 minutes. Remember that this work was really motivated, that is the proton non-hyperpolarized work, was really motivated by DoD neuroimaging, right? We're really thinking about warfighter neuroimaging. And so if you have to wait 40 minutes for a scan, that was a deal breaker. So how about flash, right? Flash is a good category of sequence. It's got fast in its name. So how does that work? You use a small tip angle, right? So you don't perturb your longitudinal magnetization, and then you crush your magnetization afterwards. You can go as fast as you want. typically limited by your hardware. So in my case, it's around 25 millisecond TR. So you're taking data about 30 times faster. But remember, these small tip angles means lower SNR. And so in fact, in this example, you have to actually average even more just to get back to the same place you would be with gradient echo. And then the outcome in both of these cases is that the total acquisition time is about the same. So the real innovation, pulse sequence-wise, from my group was the use of SSFP, right? SSFP, a very valuable sequence, right? It's fully refocused with short TRs. And the idea as a cartoon, of course, is you coherently drive the magnetization back and forth very rapidly with large tip angles, and you come to a steady state within a couple shots that's quite large. In fact, at these field strengths, it can be as large as half of M0, right? And so this kind of gets us to kind of the rules of low field magnetic resonance, which is, when you have low SNR, make the most of what you have. So large tip angles, sample all your magnetization, don't waste anything. So typically crushing is kind of a bad idea, and don't delay, right? If you have long dead times, you're not taking data. Of course, Herman Carr knew this in 1958 when he wrote down SSFP. He wasn't doing imaging, of course, he was doing spectroscopy, but he had long T1s and he had low magnetic fields as well. So when you do SSFP, and again, this is from our 2015 paper, this is 3D imaging that took about 6 minutes to acquire, about 2.5 millimeter in plane, 6.5 millitesla. Compare that to what I showed you earlier, which was in the same scanner at the same field strength with the wrong sequence, right? So if you want to do these things at low field, thinking about data rate, right? The rate at which you take data, the rate at which you can acquire information is very important for evaluating sequences. Just very briefly, our coils look like this. They're a little bit different from what many of you are used to. This is technology we developed in my lab. A very, very interesting thing to think about. Our Larmor frequency is 276 kilohertz, right? And so the way we tune and match these coils is we wind them on this former. We hook it up to a 1935 decade capacitor boxes. We turn and match to tune those values, and then we read the values and solder them in. Incredibly easy. My group is right down the hall from Larry Wald's Advanced RF Lab, and they're building coils for 7T. And so, this is one of the few things that are easier at low field. So, of course, SSFP is an interesting sequence, but it's not used too much for whole head imaging at high field for a very interesting reason. What I've written down here is the steady state transverse magnetization as a function of frequency offset. So if you want to operate in this region here, where you don't get the so-called banding artifact, where the signal goes to zero, you need to hold an absolute homogeneity, not a fractional homogeneity, an absolute homogeneity of less than around 10 hertz over your whole field of view. Very easy at low field. That's 36 parts per million at 6.5 millitesla, but that's 100 parts per billion at 3 Tesla, which, as all of you know, is impossible, because even if your magnet was shimmed that well, magnetic susceptibility artifacts from, say, the air sinus interface cause banding. And so here's the same subject, 3T and 6.5 millitesla, and at our low fields, we don't see any banding. Right away, this gives you an interesting idea that sometimes you can get more information at low field than at high field. So this was a patient imaged at 3T and 6.5 millitesla. They had open skull TBI, traumatic open skull TBI, followed by surgical resection, and the cranioplasty was lined with a titanium mesh. And interestingly, when we scan this subject at low field, look at the surgical margins here in green. This patient appears to have more brain at low field, right? Well, of course, they don't have more brain. They have less susceptibility artifact. And so the interesting thing is, if you were monitoring this patient following the surgical resection, you might miss a hemorrhage or bleed at high field, but you'd be able to see it at low field. Okay, so SSFP, it's maximally efficient at low field. The signal goes like T2 over T1. At our ultra low field, that ratio is unity. And so, we have very, very nice ways to acquire data. But of course, contrast is what all the neuroradiologists care about. And our images are kind of like proton density, which is really a shame, because as many of you know, I've plotted here T1 versus field strength. And there's a lot of interesting T1 dispersion in the range where we operate. And we have no way to tap that with this fast sequence. Okay, so far, I've talked about ways that you can make pretty good images at ultra low field if you have a high data rate and you do signal averaging. Another approach to maintain a high data rate is to continuously dither your acquisition parameters, like your tip angle and your TRs. This comes out of the really pioneering work from Dan Ma and Mark Griswold of fingerprinting. And so this is what fingerprinting looks like at 6.5 millitesla in a structured phantom. You can see here on the left, we're changing the tip angle and the TR. The images are coming in. There actually is banding because the TRs are getting quite long. You acquire all of this data, and then you plot the signal trajectory at each voxel as a function of shot. When you reconstruct this, historically, people use the dot product match, but we use something that we call drone, which is a deep reconstruction network approach. You not only can recover proton density, but all the interesting quantitative relaxation properties as well as field maps. Doing this in vivo works as well. This is data from a number of years ago, and now we actually have a fast way to interrogate this region, which is quite nice. I did mention our coils, and for those of you who are interested in hardware, you might care about this. This is a structured phantom in one of these helmet-shaped coils. You can see that B1 homogeneity actually kind of falls off as we get further away from the crown of the head. So this is work by my postdoc Shang that was published in 2021, where you can actually solve this. Again, these low frequencies are kind of like DC, right? So you don't need to do some fancy EM solver. You can just use the Biot-Savart equations and a linear programming model. And so we just come up with an algorithmic approach for deciding how many turns to put at each one of these little grooves, and you can make these very, very nice homogeneous coils. We're also doing this now for breast imaging. So, you can continue to innovate in this space. We have a quadrature coil, which works quite nicely, built by now junior faculty in our lab, Neha Kunju. Of course, this is just taking a page from David Holt's work. At some point in time, we've got like the best coils, we've got really efficient sequences, our noise floor is at the Johnson noise limit. Like, is that it for us at ultra low field? The joke in my lab used to be like, well, we can't make the signal any higher. Can we just like delete the noise, right? And so many of you are familiar with the work from my former postdoc, Bo Zhu. We published this in Nature back in 2018. It's what we call AutoMap, automated transform by manifold approximation, excuse me. And the idea is that it's an end-to-end, it treats reconstruction in general, not just for magnetic resonance, as an end-to-end supervised learning task where you go directly from the sensor domain, say K-space, to the image domain through a learned approach. And this data-driven approach, which is really trained on the forward model, remember, these problems are easy to write down the forward model for, right? We can do that like in second grade, we know how to write down the forward model for, say, Cartesian MR. Solving the inverse problem can be challenging in certain cases, right? So AutoMap learns to invert an arbitrary forward model, which is very interesting, but also the low-dimensional internal representation in the neural network is a learned joint sparse manifold that actually allows you to become more immune to noise and improve your RMSE and SNR. This is what it looks like when it's trained. It's a very simple network. This was very early in the space of machine learning. We're one of the first people to actually go directly from K-space to reconstructed images. This is from the Nature paper. Many of you have seen this. The nice thing about this trained approach is it allows you to go from, again, any encoding to the image domain, improving SNR in all cases. Most importantly for this talk, let's look at it at low SNR. So here's a funny experiment. 800 averages, right? I can hear all of you chuckling. A single slice in a structured phantom, it took 26 minutes at 6.5 millitesla, and the learned approach and the Fourier approach look the same. But as you take less and less data, you can see that the learned approach outperforms the SNR in accuracy of the Fourier transform approach. And I've plotted here, not the best metric, but it's the ratio of SNR from the learned approach to the FFT approach. Doing this in vivo was really nice. Neha published this back in 2021. We get improved SNR increases of around a factor of 1.5 to 2.5. And interestingly, the scanner was misbehaving this day. There's a bit of a zipper artifact, and you can see that AutoMap just removed it, right? How is that possible? We didn't train the network to know anything about zipper artifacts, but the network was trained, again, on the forward encoding of natural images. Right? Natural images, things that humans think are visually interesting, cats and birds and flowers and brains and all kinds of things like this. An artifact that goes from bright to dark, from bright to dark to bright to dark is very unnatural. You don't actually generally see this in natural images. And so the network just says, oh yeah, we're going to attenuate that in the transformation. So this very nonlinear learned approach is very beneficial in the low SNR regime. Okay, so like, have we solved low field MRI? Well, we've learned a lot in my lab from 6.5 millitesla experiments. being able to do SSFP, so magnets that have sufficient homogeneity, high efficiency coils, fingerprinting for contrast, automap. Incidentally, all of these things are benefit from GPU. That gets you pretty good images, right? And then, of course, once you understand the low field physics, you can come up with different instantiations of how you're going to do this. This is a figure from a 2007 DARPA proposal that I put together. This magnet has the same homogeneity as our big magnet. And of course, I did mention that SNR goes like b to the 3/2. And so you can, of course, tweak that magnetic field a little bit if you're interested in improving the SNR. So, of course, right, realizing that once you understand the low field physics means you could build application-specific scanners, led Ron Walsworth, Jonathan Rothberg, and I in 2014 to found Hyperfine. So, of course, here's the 64 millitesla Hyperfine scanner next to the 6.5 millitesla, let's call it physics machine. Taylor is going to talk about all of these results. I just want to kind of give a little teaser here. You know, once you can do MRI at the bedside, it's just remarkable what's possible. Okay, this is, of course, the Hyperfine scanner at the bedside with a comatose patient at Yale New Haven Hospital. So I will skip through these things and the work that the three of us, Kevin Shea at Yale, Taylor at MGH, and myself as the 3 PIs of a AHA Collaborative Science Award have been able to do, which he will talk about. And, you know, really, again, thinking about the initial motivation for the neuroimaging sector of my career, not the lung imaging sector of my career from 20 years ago, location matters, right? Operation at low magnetic field is what matters. This is some other work that's come out recently from our collaboration. This is work from my colleague Eugenio Iglesias, where we're using now super resolution approaches to take low field portable MRI, bedside MRI, make synthetic high resolution images, which are actually not that accurate compared to the high field ground truth. But when you segment them, they are extremely accurate and give you quantitative morphological measurements that are comparable with high field work. Okay, so in the, I don't know, 7 minutes I have left, I want to talk about like what's next for us in my lab. I didn't just shutter my lab when I founded Hyperfine. We continue to do interesting physics things in this low field regime, because some things are better at low field, some things are impossible at high field, and some things are just plain old different. And I want to give a taste of some of these things. So I'm at the Martino Center, right? You know, where Jack Beliveau and Bruce Rosen did their seminal work in bold imaging. And so functional imaging is a thing everyone asks me, right? And as we know, bold is a functional imaging approach that takes advantage of the differences in magnetic susceptibility between oxy and deoxyhemoglobin. And as such, it's really the realm of high and increasingly ultra high field MR. So what kind of magic can I show you that gives us bold contrast at low field? Well, there is no magic. There is no bold contrast at 6.5 millitesla. So what we've been working on actually is something that Larry Wald and Thomas Fitzel wrote down in 2008, which is that you could spin lock to the neuronal frequency that you're interested in, and then the NMR signal would be modulated by the presence of an endogenous, say, nanotesla level neuronal stimulus field. The problem with this approach is that actually, if you do these experiments, say at 3 Tesla, the bold effect can dominate. And SAR, remember, it's a spin lock pulse, right, can really limit how long you can apply the spin lock pulse. So now all of you listening are experts as to why we can do this at low field. There's no bold. SAR goes like B squared. So, or omega squared, right? And so you can apply very, very long spin locks at low field. And the thing you're trying to measure in this case, the endogenous neuronal signal, is independent of whatever field you're applying this at. So this is work that was done by Brage Svensson when he was a postdoc in my group. Now he's a junior faculty member at the Martino Center, published in 2020. And we call it steady state SIRS. So here's an SSFP sequence, and we wrap a spin lock experiment inside of there. If there's any stimulus current, any neuronal signal at the frequency at which we're spin locking, we see a large shift in tip angle, which builds up over many shots. It gives you a huge effect on the steady state signal. It's like a 1% effect for a 1 nanotesla field. And so this is really an interesting approach. So I want to jump a little bit and talk about something that may seem out of the ordinary, but again, this is the portable MRI journal, right? You never said portable medical MRI. So, you know, I've showed you already that reduced susceptibility can eliminate this bold confound for functional imaging. Sometimes it can give you more information. It also enables field operation. And actually, in this case, I literally mean MRI in the field, in the hot sun of plants in College Station, Texas. This is a big ARPA-E project that I co-lead. And we're not the first person to do plant root imaging. This is Paul Bottomley, you know, what didn't Paul Bottomley do back in 1986? But within a year, he recognized that doing this in natural soils, in clay soils, really produces poor images at 1.5T. And so we built a scanner that operates at 2 megahertz, that's 47 millitesla, put it right there in the ground. And these are some images that we're making of plant roots in Texas. I should talk a little bit about contrast. I'm being conscious about the time here. So this is another question people always ask about. Can you use gadolinium at 6.5 millitesla? Remember, where I work is 6.5 millitesla. Well, the reality is you can't give enough gadolinium at my field strength owing to the low relaxivity and small paramagnetism of gadolinium. And so what we've been working on for the past couple of years, this is work by my former student, David Waddington, that we published in Science Advances in 2020, using spions, so super paramagnetic iron oxide nanoparticles. These can have huge magnetizations, and these magnetizations actually persist into the ultra low field regime. So, I was showing you before that there's no magnetic susceptibility artifact at our field strengths, right? But when you put, 300 micromolar of these 25 nanometer spions and do SSFP, oh my God, look at all that banding, right? And so we've used this actually to make your signal more or less sensitive to the off-resonance signal just by changing the tip angle and exploiting the selectivity of SSFP. And so here's some examples from the paper. This is in rats. So if you go on resonance, this blue curve here, your contrast is really about, you get relaxivity contrast because you're only looking at the on resonance signal. So this is kind of what you would expect, right? You get dark relaxivity contrast, the lungs, the liver, the kidney, and the spleen. But if you do the same measurement, but change the tip angle to say 20 degrees, you're operating here on this red curve. So you get bright signal when you're off resonance. And so here, in this case, the liver lights up. So we're getting either susceptibility contrast or relaxivity contrast, depending on where you operate. That's kind of an interesting strategy. I have to cut through all of these things, which I wanted to share with you. I'm going to actually just quickly talk about this. So hyperpolarization, again, I started this talk about hyperpolarization. In that case, we were taking helium-3 and doing optical pumping spin exchange and then inhaling or transporting that hyperpolarized agent. Overhauser DNP, right, which operates on the electron-proton coupling through the hyperfine interaction, is a very interesting way to do hyperpolarization, and you can actually do it in situ. So this is work that we've done with nanodiamonds, published in Nature Comms in 2017. Nanodiamonds are very small. You can tell from their name, 125 nanometer. In this case, they have all of these little surface defects, which are electron-like. So each one of those is like a Bohr magneton. Remember, Bohr magnetons, 660 times higher magnetic moment than protons at any field strength. And so we use the hyperfine interaction, the electron-proton double resonance interaction to transfer that in aqueous solutions. And so here's an example right out of the paper. So these gray vials contain aqueous solutions of nanodiamonds. The white vials are just water, regular MRI, magnitude and phase. You cannot tell the players apart. But when you turn on the electron saturation field, which is 191 megahertz at our field strength, the diamonds light up. So this is amazing, right? So what we're doing is, number one, we're doing electron saturation, which you can do in vivo at these field strengths, 190 megahertz, right? And this isn't relaxation contrast. This is hyperpolarization that turns on and off with RF controllable saturation fields. This is the last slide I'll show about this. We have done this in vivo. We published some of this work in 2018. This is in a rat model, an MCA occlusion, where there was injected stable free radicals, and you can see the signal lights right up, and you get a huge enhancement and phase inversion in this case. Let me jump to the end. Oh, that is the end. So hopefully I've convinced some of you that MRI is possible in the Millitesla regime, despite there being lots of things to keep you up at night, mostly obsessing about noise floor. And of course, Taylor is going to dig into the real practical uses of this technology. But in my case, it's really from a combination of physics and compute. I gave a few examples, and I skipped over a few examples of interesting use cases for magnetic resonance experiments, both MRI and NMR at low field, some of which use hyperpolarization, some of which don't. The implications for healthcare, again, Taylor is going to talk about this, but, it's very interesting to think about what Steve Schiff, who's a pediatric neurosurgeon, many of you know him, really said low-cost MRI could revolutionize medical care, and here he is at the Care Children's Hospital in Uganda. What I want to talk about with all of you afterwards in the panel is as I said, some applications honestly benefit from low field. Not all applications. It's not the cure for everything. How will each of you want to use these tools in the 21st century? And I know I've gone over time. I have to acknowledge my group, members past and present, and our funding agencies. And thank you very much for putting up with me.
Thank you, Dr. Rosen.
Thank you, Dr. Rosen. That was really an outstanding presentation. And I have to say, I was not expecting to find out that from your perspective, the hyperfine scanner is a high field unit.
Oh, absolutely.
So it's really remarkable to see, you know, the ability to produce images and the thought process that goes behind changing the pulse sequence design and even what is generating the image contrast. That was really fascinating to me. So I thank you for that. What we're going to do is hold questions for now and go straight into the next talk, and then just to let the members who are signed on know that we'll have a question and answer at the end, and if we run over a little bit, if people are willing to stay, we'll keep going until for a little bit longer if we need to for the question and answer. So it's my pleasure now to introduce Dr. Taylor Kimberly. Dr. Kimberly is the chief of the Division of Neurocritical Care at Massachusetts General Hospital and associate professor of neurology at Harvard Medical School. He's a clinical neurologist. He looks after patients in the neurocritical care ICU and in the neuro recovery clinic, and also leads a research group that conducts translational studies, bridging basic science and patient-oriented research. He's recognized for developing blood and imaging biomarkers for clinical trials in brain edema, is a co-PI of phase 3 CHARM trial, and his laboratory has been developing and researching clinical applications of low-field MRI in the inpatient-outpatient setting. Outside of work, Taylor enjoys Nordic skiing, cycling, and hiking with his wife and 3 daughters, and it's a great privilege to have him here to talk to us about their experience with the ultra-low-field MRI at Mass General.
Thanks, Aditya. I didn't actually realize you were going to share that last little bit, but thank you for doing so. Thank you also for the invitation to participate in this webinar and the opportunity to talk about clinical applications of low field MRI. Let me pull up my slides here. Okay, good. So you heard what I thought was an excellent summary of some of the physics and scientific underpinnings of low field or ultra low field MRI. I'll pick up the story and talk a little bit about our experience in using this in clinical application. But first, moment. There we are. My disclosures, and again, just to point out, of these, I do have, through my institution, a sponsored research agreement with Hyperfine. So you heard a wonderful historical perspective from Matt, dating back many years. My involvement in low field portable MRI came a little bit later in the stage of development, back in around 2015, 2016, as Hyperfine was getting started. I had the opportunity to join with Matt and Kevin Sheth at Yale and partner with Hyperfine to think about ways that low field MRI could be used in the clinical setting. And one of the things that I find striking in terms of thinking about the last 5 years or so is just the rate of development in the quality of the images coming off a scanner at 64 millitesla. And these images show that over a period of the first several years, some of the proof of concept imaging was coming off this scanner, which is, as Matt said, is 10 times higher magnetic field than the 6.5 millitesla research unit that's in his lab, and that the options and availability of additional pulse sequences, including by 2017 into 2018, DWI imaging really created a suite of sequences that opened the door for clinical applications. And one thing that I would say is that when thinking about the translation from proof of principle, demonstration of ability to image, and then thinking about applying that into a clinical setting, it obviously has to apply. You have to have a harmonized form factor and unit that can work for all sorts of individuals, and it also has to have a core set of imaging sequences. And in those first few years, that was clearly the focus of development, such that by 2018, when the first scanner was installed over at Yale in Kevin's group, there were a series of standard sequences that we're all familiar with, and there were images being generated off the low field scanner that look very much like the types of scans that we see on conventional MR, except with lower resolution. The one caveat is that the time needed to acquire these images each were in the 10 to 15 minute range. And then 2 years later, and I was I was amused to see that Matt had the very same photo. We received a unit over here at MGH in our neuro ICU, one of now 3 units that we've been working with. And very quickly during that period of time, the quality of the pulse sequences, as well as most recently, some of the hardware has improved, so that now the image quality that's coming out, and I'm showing here an example of a stroke patient with a right MCA stroke, we're able to get a detection of pathology, and the scan acquisition times are really comparable or nearly comparable to conventional MR. So this development timeline from 2015 or so up to current day has really undergone tremendous leaps and bounds. Now, the one thing I would say is we know there's, when thinking about imaging and thinking about its application to clinical scenarios, there's this interaction, almost like a triangle, between the length of time of an acquisition or a sequence, the resolution, and then the sensitivity for detecting pathology. And there's always an interaction between each of these. Generally, you can't tip the scales towards one without affecting the impact on one of those other factors. And that's always been the challenge in figuring out how to apply, frankly, MR in any scenario, but certainly applies in the low field regime as well. Of course, one other element that is embedded in a portable MRI is really a fourth dimension, and that's what really is, at least as a clinician, the most exciting aspect about this technology from my perspective, as I'm sure it is from yours, and that's that there's the accessibility and portability, so that this fourth dimension allows us to conceive of applications for this scanning technology in arenas that previously were unimaginable for conventional MR. So it's really this process of identifying trade-offs between these factors and finding the right use case scenarios. And so that's really the stage at which we're at. And I apologize, I didn't include some of the proof of principle publications that, together with Kevin Sheth and Matt Rosen, we've published over the last several years, because what I really wanted to do is instead spend a few moments before we go to the Q&A session thinking about these, how we're, or I should say, sharing how we're thinking about these use case scenarios, because I think this is where the fun part is from a clinical perspective, is thinking about how to leverage the strengths of this type of technology and understanding where it can be most useful. So I'll share 2 examples of ones that we're working on, and the first is in the realm of acute stroke. And one of the features for those that may not be quite as familiar as acute stroke care today, but it's really an evolving landscape, and so placing a novel diagnostic technology within that landscape requires some careful thought. And part of the reason is that a lot of the clinical decision making is exceptionally time sensitive. And so it just needs to be thought about carefully. Moreover, the algorithms and the clinical algorithms for how to evaluate and make rapid treatment decisions within acute stroke have increased in complexity. And having come back from the International Stroke Conference last week, I can attest that those algorithms are continuing to evolve and will continue to evolve quite dramatically. But the general concept in the care of this particular patient population is that time is of the essence. So then the question arises, what is the sweet spot for a technology that has portability, but requires 15, 20 minutes of time to use the technology and not have that interfere with a time is brain clinical algorithm. And one of the important features is that imaging really is central to the evaluation and management of acute stroke patients, and it really is integral to the guidance of treatment decisions, whether it's intravenous TPA, which is a pharmacotherapy for the dissolution of clots that cause ischemic stroke, or mechanical thrombectomy, where it's an endovascular surgical approach to removing the clot. But the key is that imaging is really central to those clinical decision making. Now, portable MR and low field MR is unlikely, certainly as a starting point, is unlikely to have an easy place within that very tight time-dependent algorithm to slot in and demonstrate value. So that's really not the place to start to evaluate it in this arena. On the other hand, there is a clinical scenario where it can be exceptionally useful, and that is in the last several years, the last 5 or 10 years, it's been recognized that actually a pretty large proportion of patients, about 25% of patients, will wake up with stroke symptoms. So they'll go to bed feeling normal and they'll wake up. Since a lot of the treatment decisions depend on time and the passage of time since the stroke onset, this patient population typically does not qualify for treatment. But it's likely that they can, if there's a way to safely identify those patients who wake up with their stroke symptoms, or at the time they wake up, that's the start of the stroke, versus those who suffer a stroke in the middle of the night but don't wake up. And what was recognized is that MRI features on the T2 flare, as well as on the DWI sequence, could serve as a surrogate tissue clock in lieu of the usual time clock that defines treatment windows for thrombolysis and thrombectomy. And so this concept of being able to detect an acute ischemic stroke on the DWI, which is shown here on the top 3 examples, where a hyperintense stroke lesion on these 3 cases, where on the T2 flare, if it is undetectable, it really matches folks who have a stroke that are 3 or 4.5 hours or less in age, and that's shown on this left-hand side, where there's no hyperintensity in the region where the DWI lesion is. The middle example, where there's perhaps some subtle T2 flare hyperintensity, as well as on the right-hand side, an example where there's an obvious visible T2 flare hyperintensity that overlies the region where that is identified as a stroke. And these changes occur in a time-dependent manner. And if you leverage these features, you can identify patients who are within a 3 or 4.5 hour time window, which is the typical time window for making decisions around thrombolysis. And although it may not be that sensitive, meaning it is, there are some patients who will have flare detectable lesions in that time window. If it's clean, it's highly specific. And that's really what you want when you're making a clinical decision around using a treatment that in theory could kill someone from hemorrhagic transformation. And shown here is an example, and this was all shown in conventional MRI at 1.5 or 3T. Some of this work really out of Gertz Tamala from Germany, who really led the field 10 years ago. And what he showed on the left-hand side is that if you're in that first 0 to 60 minute or first hour window, 2, 3, or 4 hour window, there's an enrichment for patients that are flare negative. There still will be some flare positive, but as long as you're reasonably confident that someone is flare negative and within that 4.5 hour time window, then you're good to go to make a thrombolysis decision. And to his credit, he was able to organize a multi-center randomized clinical trial called the Wake Up trial, where he used MRI as a tissue clock to guide thrombolysis in patients who had an unknown stroke on time of onset. And what's remarkable is that those individuals those patients who were allocated randomly to thrombolysis had a better 3-month outcome compared to those who were allocated to placebo, as shown in this modified Rankin scale score, which is a scale of disability where the lighter the color is better, the darker the color is bad. And you can see on the top set of bars that there is a larger proportion of lighter color relative to darker color. And so this really demonstrates the principle that MRI can be used in this patient population to select treatment. That that's great, and this was really an exciting result back in 2018 when the Wake Up investigators shared that. But the reality is that at most hospitals and most emergency rooms, they don't have access to a conventional MRI, particularly one in that hyperacute setting that can be used to guide this treatment. So this is really an exciting result, but it's not really applicable or accessible to most patients who present to emergency rooms. So that really, because of that lack of accessibility, but the proof of this principle in guiding clinical decisions, this really is the sweet spot for low field and portable MRI. Again, Matt had briefly touched on this as well, and again, I'll just highlight it again that we have shown together with Kevin Sheth that the scanner is capable of acquiring their proof of principle that it can acquire T2, flare, and DWI images in stroke patients. This was performed in this subacute setting, so patients who were largely a day or later after their stroke onset. But again, it showed that these images could be acquired and could even be acquired in critically ill or in patients with complex medical disorders, not a trivial feature. And so what that's done is guided us on a current effort together with Hyperfine and 2 other academic medical centers. We're conducting a study where we're enrolling, rather than subacute patients, acute stroke patients, obviously with an enrichment in the first 4.5 to 6 hours, but we're taking patients up to the first 24 hours, and we've created a streamlined imaging protocol that focuses on the 2 sequences that can be used for clinical decision making. And right now we're in the process of demonstrating that we can replicate this principle of flare and DWI mismatch as a tissue surrogate. And I'm showing here work that Annabelle Sorby-Adams in my group has been leading the effort on, and already, and even in some of our initial experience, we're showing that flare signal hyperintensity appears to be following that same pattern. A few examples here on the right-hand side where a flare image, these are on the left hand column of images, and a DWI B900 on the right-hand column of images at 1 hour after stroke onset, 5 hours, and 24 hours. And what's really encouraging to us is that even a very small strokes, as seen on the bottom example, are detectable in this scanner, suggesting that it'll have a sufficient safety margin for detecting these small strokes and helping guide these decisions ultimately when combined with thrombolysis. So this is one example of, oh, and I'll say one other thing about this is that has been a principle even up to now, is that what's particularly exciting is that the quality of the sequences continues to improve through innovation, similar to what Matt had described. Similar efforts are ongoing within Hyperfine, and that has really made as a clinician seeing these scans coming off the scanner, they're really quite impressive. An example here showing a PCA stroke where the B900 ADC and flare are nicely pick up a small stroke for a patient who presented with loss of vision. Okay, so I'll move on in the interest of time and briefly touch on another use case scenario, and that is that in addition to detecting pathology, as in the example I've shared in acute stroke, another important application is a quantitative morphometry, and this the ability to segment and derive volumes of brain substructures has value not only for research applications but as well for clinical applications. One of the key features of this, though, is developing a processing or post-processing pipeline to really facilitate that process in a low field regime. And again, Matt had alluded to this together with Eugenio at the Martino Center. We've been working to develop a machine learning algorithm that Eugenio has developed. It's SynthSR, which is a super resolution algorithm that can take low resolution inputs and generate a T1 MP range 1 millimeter isotropic synthetic scan, which is shown in this middle set of images. And when compared to the authentic 1 millimeter isotropic MP range images, it's really quite extraordinary how close in similarity the results are. And in fact, both can be submitted through a semi-automated segmentation pipeline, and the volumes that are derived from those, whether it's the cerebral cortical gray matter, the white matter, the hippocampus, the CSF, the correlation and the degree of agreement is quite impressive. And so we're very interested now in leveraging that for serial and longitudinal monitoring of brain volumes, whether it be hippocampal volumes or other, for a variety of neurologic diseases, including multiple sclerosis and Alzheimer's disease. And finally, using Eugenio's algorithm, it can also be leveraged to identify errors or deviations from the expected, which is can be leveraged to identify and highlight pathology, as shown here. So there are a variety of ways in which we're exploring how this technology can be used for clinical use case scenarios. But one of the things that makes it most exciting is that there will always be a role for conventional MR, where that current paradigm where we bring the patient to the MR suite, there's always going to be a need for high resolution imaging for important diagnostic questions. But there are certain circumstances where that's either not feasible, or the portability can be leveraged for point of care imaging, and identifying those environments, whether it's the ED, the ICU, or inpatient floors in the clinics, out in the community, even in the pre-hospital setting, or in rural or low resource environments. The opportunities really are wide open for how to apply this technology for these use case scenarios. So again, a lot of exciting particular ways in which this can be developed. I shared with you two examples, including wake-up stroke and brain morphometry. And really the exciting thing is that this has the ability to democratize imaging. I'll just acknowledge not only members of my lab, but collaborators, including, of course, Matt and Eugenio, as well as Kevin, neuroradiology colleagues at MGH, as well as our emergency medicine colleagues that we collaborate with. So thanks.
Thank you, Dr. Kimberly, for that outstanding presentation and that look at one of the emerging applications of this technology. So we do have a couple of questions in the chat. So I think we'll start with one that was emailed in. So this one came from Dr. Frank Shellack, who's well known in the MRI community for his work in MRI safety. And his question, which really applies to all of us, I guess, on the panel, but maybe we could start with you, Taylor, is he asked about specifically if any medical implants have been tested and labeled for scanners operating below 1.5 T. So actually, maybe that's one to ask Eddie. But then he asked how we manage patients referred for MRI exams. And I guess I'll broaden it a bit and ask if people would comment on whether they are scanning patients who are considered to be classically contraindicated at high field. So maybe Eddie, just to start, do you know whether any implants are actually specifically rated at ultra low? My feeling about what I've seen is that most of them specify a field strength not to be exceeded, if you will, but they don't prohibit the lower field. Do you have anything more to comment regarding anything specifically labeled for scanners below 1.5 T?
Aditya, that's correct. So nothing is specific at this point in time. Any usages are being done off-label, and we have seen a lot of our clinical sites doing off-label imaging without any untoward effect. There are also some sites that are undergoing a more research approach to investigating things such as pacemakers, implantable cardiac defibrillators. That being said, in addition, and I saw this was a question as well, we have 2 sites as part of a study that are looking at the scanner within the ECMO environment themselves. We have some anecdotal people, again, all off-label. The research sites are being done under IRB, but anecdotally, additional sites, ECMO patients with external pacemaker devices. And again, no one has found any sort of adverse event with any of these things. But again, it's all off-label at this point in time until further testing is done or our instructions for use is further modified and approved by the FDA.
Yeah, I would just add a couple other dimensions from a clinical perspective. I think it really is, it's a matter of risk tolerance as the clinical provider, whether you're willing to take that risk. I think, and probably Frank and others can comment more in a more informed way, but I suspect the FDA has a slightly more conservative stance, and that's fair. That's their prerogative. I do think that certainly the expectation, just based on the physics that Matt can explain better than I, the expectation is that these devices certainly will be safe. I'll say in our own experience, we've scanned patients with a mechanical ventilator, with CVVH or renal replacement therapy devices, infusion pumps that are infusing life-saving medications, and so really high high risk environment. We've not encountered any safety concerns. So I think as a field, collectively, we have to decide what's a reasonable set of parameters to approach this. And I suspect that there might, institutions might come up with a different set of criteria or local criteria. But I will mention that, again, a lot of these pacers, by the way, are also quite compatible with conventional MR, and that was demonstrated in a trial. And so that's certainly one mechanism in which we, collectively as a field, we could pursue that if it ends up being a barrier to imaging these patients. But I think there's unequivocally, this is an area where a low magnetic field device really shines.
I agree with both of those things. And just to sort of say, along what Eddie was saying, from the research side, in my group at 6.5 millitesla, we've been working with some colleagues at Yale, and we've been looking at spinal implants and things like this, which are non-magnetic per se, but they're they may be paramagnetic, and we've been looking at sort of reduction of susceptibility artifact issues. I think, to follow on what Taylor said, operation at low field, it's beneficial in two ways, of course, right? There's the tug, which is reduced, but also the SAR is really a concern. I'm actually on the MR safety committee at Martinos, and we have to deal with on a daily basis almost issues around our 7T, right? And so we're very, very careful because of deposited power. So operation at low field, be it 64 or 6.5 millitesla, is beneficial in that regard. Just to frame discussions going forward, I want to clarify that at least in my group and in papers from our collaboration, we refer to ultra low field based on the Los Alamos definition of 10 millitesla and lower. So ultra low field is below 10 millitesla, 64 millitesla is low field. So that just so we don't get our wires crossed.
So I guess a question that also comes up with respect to these implants is that many of them have requirements for checking the programming and the mode that the implants are set into. So do you have any insight into whether at low field or very low field and then at ultra low field, whether that type of programming is still required? Because from a clinical standpoint, that can get in our way sometimes in the ICU environment and so on, getting the personnel in to do that.
I have no comment on that. Eddie, do you have any thoughts about that?
Again, officially, you have to kind of follow the manufacturer's guidelines. Anecdotally, from a variety of things, there haven't been any changes. For instance, programmable shunts in our pediatric hydrocephalus study and the like. But officially, party line, you have to follow the guidelines.
I agree. I think as long as we need to develop an empirical evidence basis for it, and I think as that accumulates, I think the comfort level for that safety factor will increase as well.
Wasn't there just an announcement from FDA where 5 Gauss line is now 9 Gauss line? I mean, didn't that just, there was, I saw something the other day about this. So slow progress, but at least there are things.
Okay, I'll ask one more, and I think Omar has one of the other audience questions, but there's one more that was entered in the chat, so let me just ask about that. Oh, actually, and I just will add, Dr. Stolick actually added that based on his experience, he doesn't know of any passive implant that's been tested and labeled at 1.5 or 3 that would pose a risk to a patient undergoing MRI operating below 1.5, which I think makes a lot of sense. So
the other thing I would add to that, Adish, is it has to be within the 5 or 9 Gauss line. Right. So in this scanner, you're talking about 2.5 feet from the tip of your nose. So anything subclavicular and beyond
would be outside of the field.
Actually, if I may, Eddie brings up a very valuable point, right? Because we're talking, as patients get older, as the patient population gets older, people have hips and knees, right? And those people are precluded from high field may be precluded from high field neuroscans, but they could be scanned on these purpose-built smaller scanners. So that's a very, very good point.
So there are two that actually I'm going to link together, which are that, and these are questions about stroke. They're kind of related. One is whether we can reproduce the detection of hemorrhage that we currently use CT for, and thereby include or exclude patients for RTPA. And the other is just a general question for you, Dr. Kimberly, about what you feel the optimal scan time is then in which you would want to image for this, when trying to time the stroke in terms of where looking for a mismatch of DWI versus flare catching up to it, so to speak, would fit into your workflow. When do you envision using the imaging? So the first is hemorrhage, and the second is where and what time frame does this fit into your stroke workflow for imaging?
Yeah, I'm going to answer the DWI flare mismatch first, because I think it ties into this other conversation, which is if you can sort of streamline the process of getting a patient into the scanner, I mean, that just it just sort of moves everything along. And so if in a future state, we don't even have to think about implants and their effect, that really is transformational, because a lot of the time and energy and minutes are spent, frankly, much more than the image acquisition, are spent trying to figure out what make and model of XYZ implant is in there. So I think all of these are interrelated, but I just want to highlight that as a key step in really in highlighting the value of the low field scanner. So then the answer, I mean, as always with clinical patients, is that there's every type of patient out there where some can tolerate for 30 minutes. others for 30 seconds. In general, as a rule of thumb, clinical patients are less able to remain still than normal healthy volunteers. I would say that we're now in the realm of about 15 minutes for for acquiring these images, and that's to me that's pretty darn good. It's certainly within striking distance for embedding this in a clinical algorithm, particularly in a patient population that wouldn't have any other treatment option anyway. So I think that's to answer that question. We've also been very interested in whether this could replace CT, and perhaps using this to identify and differentiate hemorrhage from ischemic stroke. And I think there are a couple caveats to that, but I do think that's a possibility. Again, it really depends on the particulars of the algorithm. I would say as a clinician, if I'm in a scenario where I have a CT scanner where I can put, work with the radiologist to put them in in some cases, like within 10 minutes of a patient arriving to the emergency room, they're in the CT scanner. I'd say, what's the added value of trying to replace that with the low field MR? Well, there are scenarios where it's useful, but it's not going to beat the CT scanner on time, and that's okay. But there may be other scenarios where it's the sweet spot for a low field scanner. For example, in a pre-hospital setting, maybe if you envision the scanner being located in a EMS truck, and it's out in the community, and there's a stroke patient, and it's a long travel time to get into an ED, having that EMS truck with a scanner located there, meeting that patient and scanning out in the field might be an opportunity. So it depends is probably the safest way to answer that.
Mm-hmm. And I think when you're giving thrombolytic, you're looking for a test to be very, very sensitive for the detection of hemorrhage. Our experience, we've been using it in some of our trauma patients as well as operative patients. And though you can detect hemorrhage, I'm not sure the sensitivity right now would be at a level that doctors might be comfortable giving lytics. So that's one of the things that will have to be thought about. But as you say, in environments where there's no access to any other alternative imaging, then some imaging could be better than no imaging. So that really does open the door, perhaps, to these being used in those settings.
And then also, of course, and this is work that Taylor and Kevin and I have talked about. The idea now to do serial neuroimaging, not with ionizing radiation, right? So you have your initial intake CT, you make your decisions. And then really, we're kind of starting to talk about new ways of practicing medicine, right? Where you could really monitor response to therapy, quantitatively, especially using some of these morphological measurements, daily, multiple times a day. That's really, to me, I think, it's not the us versus them, it's the sort of we, right? In terms of modalities.
Mm-hmm.
I think maybe I can ask the question that I received, if that's okay, Aditya.
Yeah, please.
So first of all, I didn't get a chance, but thank you, Taylor and Matt. Wonderful talks, amazing work that's happening there down in Harvard. Matt, just an amazing lab you have down there. It's an absolute genius. It's like, if I use two words, it's absolute genius what you guys are doing there. So the question I have is on the contrast agents for low field. And the question is, and I'll read it out. In high field, we use brute force techniques for gadolinium, and I presume they're saying, looking at blood-brain barrier breakdown for MS, abscess, tumors, metastases. However, in low field, it has forced us to think outside the box. Can you elaborate on what you see the future for low field MRI and disease-specific contrast agents?
Yeah, so that's an amazing question. So I did mention very briefly about these SPION materials, which are very, very interesting. We've been working with those materials, both functionalized and non-functionalized. They work great. There are ways, again, to get both bright contrast and dark contrast, depending on how you operate with them sequence-wise. One thing which I did not get to talk about are the use of hyperpolarized functional agents. So things like SABRE, which is a parahydrogen-based hyperpolarization method, is extremely efficient at ultra low field. And in fact, for proton hyperpolarization, it turns out it's maximally efficient at 6.5 millitesla. I didn't know that 20 years ago when I built my scanner. And we've shown, and this is through a big collaboration with Thomas Tice at NC State and Ed Checkman at Wayne State and Boyd Goodson at SIU, Carbondale, that you can hyperpolarize, deliver, and image all kinds of functional processes, not just the thing that people know about like C13 pyruvate, which people typically use DNP for, but other interesting things like FDA-approved molecules like metronidazole. These things can have 20-minute T1s in vivo. So I think what's happening is that hyperpolarization from molecular imaging approaches has been going on as a field for, when I was in grad school in the 90s, we were talking about that, right? At the same time, low field MRI is coming to maturity. These hyperpolarized agents can be used for high field, as they've been for a while, but there's essentially no loss in SNR using them at low field. Again, these are exogenously polarized agents. So this is a long answer, I apologize. But I think in terms of molecular imaging, functional imaging, metabolic functional imaging of the type of things like blood barrier breakdown or redox status, or things like this in vivo, it will probably be some combination of new, maybe spion-based materials, or manganese. Manganese is coming online as well, and hyperpolarization.
Yes, thank you. It's a whole new exciting field, and I think we'll have to have you back. We'll have to have you back and just talk about contrast and low field.
I would love to. I mean, like low field MRI is democratizing magnetic resonance imaging, right? Hyperpolarization stands to democratize molecular imaging and PET imaging, right? PET is, of course, amazing. We count single photons and they always have that sensitivity against MRI, but there are lots of interesting use cases for hyperpolarization and low field. So.
Thank you. Aditya, I think there are a couple of more questions in the box. Maybe we can do those two, and then we've gone quite a ways over time, but that's okay. Interesting talk and subject, so I think we have to give it its due attention. So I'm going to ask the one question from an anonymous attendee. What is the lowest possible detectable spatial resolution for ischemic changes and for hemorrhage in your experience? So maybe, actually, perhaps both Eddie and Taylor can speak to this. And
Taylor and Kevin both have reported on that, so I'll defer to Taylor, citing the works in separate studies, one for each.
Yeah, Eddie, I was hoping you would actually answer, because I don't
think fair enough.
Measured the exact millimeter size. It's somewhere around, somewhere around.
So in their reported
size, but I have to confess, I don't have the number off the top of my head.
In their reported studies, they were saying 4 millimeter detection for acute ischemic stroke as well as intraparenchymal hemorrhage. That being said, our typical slice thickness effective, these are 3D sequences, is 5 millimeters. So I throw it out there when I'm asked, approximately 5 millimeter detection for acute ischemic stroke, as well as intraparenchymal hemorrhage, with the caveat, inferior posterior fossa, due to greater brain motion, it's going to fall down a little bit. I don't know if Aditya wants to comment based on his clinical experience as well.
Yeah, I think that sort of gels with what we have found. The flare is probably the kind of workhorse sequence for deciding whether a lesion is present because of artifacts still on our version of the DWI. We're excited to see the one that Dr. Kimberly is working with now. But and yeah, the other challenge with the posterior fossa is that it's very sensitive to patient positioning within the coil, and so we have trouble sometimes getting good coverage of the posterior fossa. So yeah, I think that gels with what we've experienced. But I will state that in terms of detecting hemorrhage, at least for me, I've been looking for sort of T1 hyperintensity. That's sort of been the usual clue that you're looking at hemorrhage. And we have seen cases of small subcortical hemorrhages that are simply not visible on the low field system, at least currently. And so I don't have a lower limit of detection of hemorrhage, which I think will be an important factor for if you're making decisions about thrombolytic therapy. So I don't quite have that number down. What
Thank
do you
you.
think, Taylor? Do you have any?
Yeah, no, I agree with everything you said. I think the 5 millimeter threshold is certainly the case. I think it's probably, in my experience, a little bit lower, but I think that's a good rule of thumb. And just in terms of the newer hardware and software in relation to coverage of the posterior fossa and the DWI sequence, I'll say in our experience, there's substantial and notable improvements that we've observed.
Taylor, how about correlates with flare with T1? For us at ultra low field, T1 is kind of a proxy for diffusion, because T1, you're looking at correlations at kind of 1 over the Larmor frequency, which is a couple microseconds for us, which is like macromolecular exchange. So in rat MCA occlusion models, we see hyperacute stroke on T1 with T1 changes of like 25 to 30% in like 10 minutes. So have you seen clinically any markers on T1, just out of curiosity, for stroke?
Yeah, I mean, certainly it's the T1 hypointensity is really quite obvious, particularly in the subacute phase.
Yeah,
I think in the hyperacute phase, the B900 has really gotten quite good, and that the SNR is sufficient. We're just visually by eye, you can now see very reliably a stroke. So I mean, I think that sort of answers the clinical question.
Yeah. It's one of those interesting differences in field strength where native T1, if you're at the correct field strength, which is too low to make really good images, gives you stroke contrast. It's just one of those funny things.
Yeah.
Okay, one last question, and I'll pass it back to Aditya to summarize and close this webinar. This is from Dr. Etta Wallace, and our question is, there are remote hospitals or locations in Canada which would benefit for remote management of these patients. Is there any work going on with them? Maybe I'll just answer that briefly from our experience. So here at Queen's University, where I am, we have a research partnership with Winnebago Area Health Authority, which is a hospital in remote Northern Ontario along the James Bay coast. And we have a 12-month project with a hyperfine unit up there right now. And the study is almost finished, and we're about ready to publish our prelim results on the feasibility of portable MRI in a remote setting. And of course, we're talking about all different things than the typical ICU patient population. And there's a lot of interesting lessons to be learned, I think, from that, and which would be applicable to not just Northern Canada, but remote parts of the world everywhere, really. There's probably a large utility of portable MRI in a remote setting compared to all the discussion we've had in ICU and in the hospital. And I think there probably are going to be lots of benefits that we don't even know of yet, not just in terms of direct patient care, but indirect impacts on public health, costs, benefits, etc. So we are looking into that with our portable MRI unit in Moose Factory, and we will have something hopefully by the end of this year to say more on that. Any other comments? And Eddie, do you have any experience from other parts of the world?
So we actually do on a couple of different fronts. There's a partnership between Hyperfine and the Bill and Melinda Gates Foundation to look at deployment in low and middle income countries where the use case is phenomenal. Actually, there was a picture of Steve Schiff in one of these typical sites. There was an earlier site in Blantyre, Malawi, where they're looking at in the setting of cerebral malaria. That was actually reported in the AJNR and presented at the ASNR about a year ago. So the ability to just take something and plug it into the wall outlet and get images clearly has a phenomenal public health benefit and effect. And absolutely, we're democratizing healthcare without a doubt.
Eddie raises a really valuable point, which is that, a lot of the work that's being done in sub-Saharan Africa is about population health as well. And it's just not ethical to use X-ray CT for population health. It's just not. You don't scan young kids to do, say, brain morphological measurements following post-infectious hydrocephalus or something like that, a screening tool with ionizing radiation. And so this really opens up, I would say, new ways of getting to the patients and getting data.
Thank you. Aditya?
Great. So I think with that, we will conclude. I'd like to thank our speakers, Dr. Rosen and Dr. Kimberly, for those excellent presentations. And thank you to Eddie for being on the panel. And I'd like to thank my co-host, Omar Islam, for organizing this with me. Just to let all of the participants know, we'd like to thank you for joining us, and we'd like you to know that the intention is to have this webcast posted on the Portable MRI Journal website, which is portablemrijournal.org. Portable MRI Journal is intended to be a free, open access, online, peer-reviewed resource for the community of scientists and radiologists and clinicians who are using this technology. It's sort of a work in progress, and we're looking to currently aggregate information there, as you'll see on the website, but also to take submissions, case reports, and really to use it to sort of build up an experience with best practice with this technology, because at least from our perspective, I feel like we're still learning very much so. Not just how to interpret the imaging, but how to operationalize and use the devices, and how to integrate them into clinical care and research. So, so we will have this webcast posted, and it's our intention to hold these periodically with people working in the field. So we hope that was useful and interesting to you, and thank you for joining us.